Okay, thanks very much, Philly, and good afternoon, everyone. So I'm going to use some slides. I hope that you can see them. Obviously, being the last speaker, inevitably many of the things that I plan to say have already been very articulately said by previous speakers. So in a way that makes it a little bit easier, but with a slight anxiety of seeing that sign coming up saying you've got your internet connection is unstable just at a crucial point. So I have lined Julian up to stand in should a disaster befall me, but let's hope that doesn't happen. So I just want to add my thanks really to all the speakers and Philly for chairing today, as well as everyone who's come along to listen and hopefully ask questions as well. And also obviously to our hosts at the Value-Based Practice Collaborating Centre, so that's much appreciated. Weirdly, I think I first met Julian at another online conference about values-based practice in about 2005. So there's some symmetry there. Quite what it tells us, I'm not so sure. But anyway, that was our first connection, I think. So could I have the next slide, please, Mahir? So Julian's already touched upon values-based practice, and this webinar is being hosted by the Collaborating Centre for Values-Based Practice. So I thought I'd just say a little bit more about what we mean by values-based practice firstly. And we've already heard examples of values. Keith described the values that are important to him. And when we talk about values in terms of values-based practice, we're not just saying, no, those lists of values that may be on an A4 piece of paper and laminated and stuck up on the wall of an office, or the corporate values in an organisation. You can see from this list that values are living things. They're things that people hold close and dear to them. They're important things about guiding our actions, guiding what we do. And everybody has values, ranging from people living with dementia, family carers, through to practitioners, their professional values, but also sometimes their personal values may come into play. Organisational values in terms of policies and procedures of NHS trusts and local authorities. Wider societal values expressed through the media and public attitudes, particularly about dementia. And values expressed in law, and I'll come back to that in a minute. But of course that means there's an enormous range of values that may be at play, as it were, in any situation when supporting a person with dementia. They may not be consistent. There may be a conflict of values sometimes, and that can be distressing for people involved. It can be problematic in providing support or knowing what kind of support to provide, particularly when the evidence or the science is somewhat limited in guiding us what to do. Now, I put an asterisk there by values expressed in law, because I think, and I'll come back to this point in a minute, because where values are expressed through law, they perhaps have a slightly different status than values expressed elsewhere. And I'll explain what I mean by that in a minute. Next slide, please. And in dementia and dementia care, supporting people with dementia, we find values everywhere. Now, Julian mentioned about using science and using evidence to guide us wherever possible. Evidence-based practice is that phrase that's often used to guide us in terms of decisions about care and support, treatment. But for those of you who are very familiar with dementia, we know that the evidence around treatment, for example, is very limited. There are very limited interventions that work particularly well. There's no cure for dementia. So that means decision-making, decisions about issues such as risk and care and treatment, inevitably values come in and guide many of our decisions, because we lack facts, we lack science. We're not led by the science a lot of the time, or not by a traditional definition of science, perhaps as people understand it. We're led by what seems to be important. We're hopefully led by the wishes and views of the person with dementia, family carers, but also professional views, the views of other people supporting someone with dementia. And I think, looking at that list, I think you can see where values come into play in many of those situations. I'll just select one because it's something that many people who know me know that it's something that's particular interest to me around truth-telling. And so when someone with dementia, perhaps with more severe dementia, is asking to see someone, perhaps a husband or wife, partner, spouse who's now deceased, but the person believes they're still alive, or they live in a care home and they're expressing that wish to go home, although they no longer have a home, their home is the care home, or perhaps they want to see an adult child, believing that adult child to be a baby, so saying, where's my baby, where's my baby? And this is an effect of dementia. It's very meaningful to the person, but the kind of evidence that we have indicates that quite often not telling the truth to that person, not telling that person that their husband is no longer alive, that not telling the truth is a better way of supporting them than constantly to tell them something which is distressing and they may not be able to remember, so results in repetitive grieving, i.e. I'm very sorry your husband died many years ago. And that can be a very distressing thing for someone with dementia to hear. But now you can see where I'm going with this. If we're therefore saying not telling the truth has some evidence base to it, that raises enormous issues about values, because some people will say, well, does that mean you're condoning lying to a person with dementia? I've always taught to be honest, and so on. So immediately one can see that even if there's an evidence base, and there is, for example, with something called doll therapy, where it's sometimes appropriate to provide someone with a doll instead of a baby, and they believe that they're holding a baby, or may believe it's holding a doll, but it provides comfort. But clearly that's not a truth that's being told to that person, but there's an evidence to support, indicate that alleviates distress. But many people would say, should we go there? Because that's a value that seems to condone lying. So I'll just leave that one with you, and I'll probably come back to it a little later, because it's a particularly acute example. Could I have the next slide, please? So the values-based practice has these two key elements. The premise, the basis of values-based practice, is about a mutual respect for differences of values. It's saying, let's not try and say we've got to all agree one set of values. Yes, of course, we can say dignity and respect are important, or fairness and so on, but we also have to acknowledge that people have different values. Some people will value their independence much over, say, safety. Some people may not hold truth-telling as the be-all and end-all of virtues, and may be perhaps a little bit more flexible around how one should respond in those situations I've described. So there has to be this mutual respect for wide differences in values. And therefore, when we're making decisions, and when I say we, that's involving the person with dementia, family carers and practitioners, we're making decisions within a framework of shared values. And by shared, I don't necessarily mean shared in as much as we all agree with them, but shared in terms of we recognise there's a whole range of values in play. I heard quite a nice phrase, I think Bill first used it, around think of values as action guiding words rather than its dignity or morality, but they just are things that are important to them and guide our actions. Another good way of understanding values in the context of values-based practice is in terms of thinking of it like an extended family. They're all related, but they don't necessarily all get on with each other. So there will be arguments and disputes, but we are all one big family. So think of values in that way. So go to the next slide, please. So values-based practice doesn't try and say these are the right values and these are the wrong values, because often all the values are right from the perspective of the person or the organisation that's holding them. There are some exceptions where values, I suppose, are expressed, such as through racism, are very oppressive to other people. There are some boundaries, but broadly speaking, there are no right and wrong values. It's about understanding the different values that, as I say, are in play in a different situation. So values-based practice doesn't say here are the answers to often very difficult dilemmas in, say, dementia care, but values-based practice offers a process to good decision making. And there are 10 elements to this process, and you can see them there described, outlined on the screen. And I'm not going to cover them all. Julian's already talked about 3. Practitioner skills, I think, are self-explanatory in terms of being aware, understanding, knowing about values. But just to go back to that example of truth-telling, so in that bottom left-hand corner that says relationships, so if the person with dementia has very strong religious convictions about always telling the truth, as do their family, then it may be that one does have to tell the truth, at least initially, to someone say about a deceased relative no longer being alive, and deal with the distress that causes. But where someone perhaps hasn't got such a strong value, or known to have such a strong value around truth telling, perhaps there is more flexibility around that. And that's where one has to understand the person, family carers. So you start off with the values of the person with dementia, but you also take into account the values of others, including practitioners. And that partnership statement, dissensus is okay. This doesn't mean that disagreement is okay or conflict is okay. It just means that we can risk having different points of view, providing we respect other points of view, and we say, well, let's try this approach first based upon what you think to be important. If that works, all well and good. But if that doesn't work, then maybe we try a different approach, using the evidence or science where we can, but based upon other people's values, and see if that works instead. So dissensus is an inclusive statement. It's not there to describe disagreements or conflict. And you can see how that could play out with, say, the example of truth-telling, if you can negotiate well and positively with everybody involved. Okay, so that's a whistle-stop tour through values-based practice. If we could have the next slide, please. I'll just try and just finish up. Oh, sorry, no, there's one more thing I want to add, and this really builds upon what's already been said about rights. There are those 10 statements around good process and values-based practice, but when we were writing Dementia Manifesto, we felt we were writing at a time when actually there'd been a real explosion of new legal frameworks over the previous 15 years, which practitioners, people with dementia, family carers, increasingly were aware of and should inform practice, often in very helpful ways, but if you don't understand the law, it can be a scary thing. So we felt, we suggested having an 11th pointer for values-based practice decision-making, which is about values-based practice working in partnership with a rights-based approach. So taking into account things like Mental Capacity Act, Care Act, Human Rights Act, etc. And that's because if you don't follow the law, there are potentially quite concrete and negative results if you get it wrong. So I'm not saying the law is the be-all and end-all, but in some ways it's a thing that people gives real focus. So the values expressed through the law are sometimes are things that people really do have to be aware of in their practice and in their lives. But, and pardon the expression there for given recent political events, but although legal values trump other values, they may not always be consistent. So we still need values-based practice to help us work out those inconsistencies. For example, there's inconsistencies between the Mental Capacity Act and the Convention on the Rights of Persons with Disabilities. There are inconsistencies in human rights legislation as well. So we still need values-based practice to help us weigh up and work out what the best thing is to do, even when we have the law around us. So next slide, please. I'm conscious that I'm out of time. I just want to say a few sort of final words about COVID, dementia, science and values. Now, as people have said, I mean, COVID's had a very detrimental and terrible effect on many people, but particularly people with dementia. Older people and people with dementia are at considerable risk from developing COVID and dying of COVID. I suppose it's just worth saying, and I'm trying to be balanced here, is that when you apply science and values over what's happened over the last year, you could put an argument forward. I think it's reasonable to say people with dementia benefited in some respects. We've seen unprecedented population-wide public health protection measures, which I suppose in many respects have been designed to protect the most vulnerable, and that includes people with dementia. So that's unusual in my lifetime. I've never seen anything like it. The speed to create vaccines and improve treatment for COVID has been unprecedented. And clearly, again, the prioritisation around older people and people in care homes receiving the vaccine, again, that in some ways will benefit older people with dementia. And this is perhaps, I was trying to be particularly fair here when I was thinking about the list of extremely clinically vulnerable conditions, which still doesn't name dementia. And being kind, I'm not sure whether this was the thinking at the Department of Health when they put the list together, but perhaps it's trying to be person-centred and recognising that many people with dementia can make decisions, can understand COVID, can make decisions about precautions and their social distancing. So why should they all be lumped together as being extremely clinically vulnerable in one big group? So as I say, I was trying to be kind there to DHSC. But if I could have the next slide, please. When you apply science and values in other ways, one certainly can say, well, dementia has been the most common pre-morbid condition, the illness that is most common that people have had prior to developing COVID and dying of COVID. So you're at greatest risk of dying of COVID if you have dementia, yet it's still not listed as an extremely clinically vulnerable condition. And I don't know if any member of the audience can suggest why it's not listed there. Now, there's 6 forms of cancer, there's asthma, there's cystic fibrosis, there's Down syndrome, which I think was added later, and some, quote unquote, some rare diseases. Why isn't dementia there? I just don't know. I don't understand. So there's that fact to take into account. And then, how come we can develop these health interventions so quickly for COVID, but still we don't seem to have effective treatments for dementia, which has been around for much longer? And what does that say about the values around different diseases and our responses to different diseases? Of course, dementia is a very different disease from COVID, but nevertheless, the science seems to be lagging behind in terms of what we've been able to achieve with COVID. And then there's all the responses that we've seen around isolation, bans on care home visits, lack of support, which have had a very negative effect on people's mental health and cognition, including obviously people with dementia. So there's increasing science, facts and evidence showing that the very things that have been done, that have been led by the science, are actually having a detrimental effect on people's lives, particularly those of people living in care homes. And I think James already has said, as have others, the decisions around hospital admissions, treatment, discharge for older people, many of whom had dementia, clearly violated, in many cases, their legal rights, their human rights. And in that desire to protect the NHS, actually lives were being sacrificed. There's 25,000 people, 26,000 people were discharged to care homes, and there are numerous examples of either being untested or tested, and those discharges resulting in outbreaks of COVID and deaths. So actually, we've been sacrificing lives and violating the right to life in other public policy measures to protect the NHS. And that's a controversial thing to say. Decisions, I'm sure, a lot of the time were made with the best intent, but actually 20% of all deaths have occurred in care homes. How come that's happened, and what's the impact been on people with dementia? Well, it's been a very detrimental and frightening impact for people still alive. So I thought just my final slide, please, and then I'll wind up. So thank you for bearing with me. Including Philly. So I wanted to end on a positive note in these times of COVID. It's slightly difficult to do, but I think there are some positives we can draw and look forward to, not only those that I mentioned, I guess, but also people are talking about how can we start building reconnections post-COVID. What do we need to do that across populations, generations, across disability groups? The way care and support has been provided has shown some ways new and innovative examples. Digital inclusion, yes, of course, many people, older people and people with dementia, can't use technology, but actually sometimes they have the technology but haven't been able to understand how to use it, and the big examples of helping people to become digitally included. So there are some positives, and I'd recommend this report to you, produced by the long-term care policy networks based at the LSE and UCL, which has some hard-hitting facts about dementia and some good recommendations, but some good examples from different countries of how COVID's been responded to. And of course, the work of the Alzheimer's Society, Dementia UK, the Ideal Research Project produced some really good leaflets, which members of the panel contributed to. The Race Equality Foundation's produced good resources for people from Black, Asian, minority ethnic communities affected by dementia. Innovations in Dementia, Deep, Tide, Carers Networks have all been working hard to produce good information. So just to conclude, well, what do those three key principles of the manifesto tell us? Remembering dementia as humanity, so remembering that a disease is about people, not just the pathology, the epidemiology of a disease. So yes, we should follow the science, but we should also listen to what people say who are experiencing disease, caring for someone with disease, whether it's dementia or COVID. Dementia as disease and disability, I think Julian put this very well, and it is a positive model of disability, the social model of disability, saying what should society do to support people with dementia and enable their participation, and Julian gave examples of that. And a key one is about hearing that voice of people with dementia, that their voice is heard, as we've heard from Jane and Keith, and we hear from many other people with dementia elsewhere about what their experience is. So when we think about dementia, values-based practice and rights, we can say, yes, of course, there's evidence there around what is good to protect people, but there's also evidence coming from people with dementia who may be saying, I want to see my loved ones, I want to connect, I may live in a care home, but I need to have that connection. Otherwise, things will get really bad for me, even if I'm in an infection-controlled environment and safe from COVID. So perhaps that's the thing that I would want to end on, about saying, let's hear more from the voice of people with dementia and other disabilities coming together in common cause. Perhaps there should be an advisory group of people with lived experiences, advising SAGE with the science, because it's about their values, what they're saying. This is our experience. It's not just about the science in a traditional way, but it's about qualitative experience and the facts that are brought together. Because if this carries on much longer in the way it's carried on so far, I don't want that to happen. I want to see a different approach taken, and I think the voice of people with lived experience is crucial in that. Okay, thank you for allowing me that extra time, Philly, and I'll stop there. Thank you.